Thank you very much for joining us. This is now the third in our series of interviews around medical innovation. We're joined today by Miss Helena Burden, who is a consultant urology surgeon at the Bristol Urological Institute at Southmead Hospital. Tell me a little bit about yourself and your areas of interest.
I'm a consultant urologist in Bristol. I've been there for about 5 years, and we're a big tertiary referral department. And my specialist area of expertise or interest is non-muscle invasive bladder cancer. But I also do a lot of core urology and diagnostics. And I work in a team of 3 of us who all specialise in muscle invasive bladder cancer. So I think we're quite a unique unit in that sense, in that we have got specialists in both non-muscle and muscle invasive bladder cancer, which really means that we can hopefully lead the way for non-muscle invasive bladder cancer in our hospital.
What does an average day in theatre look like for you?
I thought you were going to ask me about what an average day looks like rather than an average day in theatre, because quite interestingly, the average day doesn't, for a surgeon, and people quite often find this quite surprising, that we don't always operate every single day. So our average week has diagnostics, clinics and theatre. But yes, no, my theatre days in general revolve around bladder cancer mostly now. I do some core urology, but most of my lists would be a 3-session day. So starting quite early in the morning after having taken the dog for a walk, and then finishing quite late at night and hopefully seeing the children before bed. But most of my cases would be, non-muscle invasive bladder cancer, either new diagnoses or recurrent disease. And a lot of our patients, as you well know, are long-term patients, and you do get to know them quite well. So I quite often do see the same patients coming through.
What's your process of how are you doing your TURP? I know there's a lot of different, your TURB, but there's a lot of different ways of doing them at the moment. Are you using augmentative visualization systems? Are you using something clever?
Well, yeah, but it's very clever, in fact, and it's enhanced our TURBTs massively, as has a lot of the literature surrounding blue light, which we don't currently use, but a lot of the literature surrounding a lot of that has enabled our white light cystoscopies. So we do bipolar plasma TURBTs, MBT. And we use narrowband imaging to enhance them. We use that both in the diagnostic flexi suite with our HD scopes, and then when we get to theatre. So we use that as our enhancement. We tend to do them mostly as fractionated TURBTs, but the smaller ones we will do en bloc. Obviously, they'll all get a 1 shot of mitomycin as per the guidelines after the operation if they're a new diagnosis. So that's our standard. We do things possibly slightly differently to some other units in terms of we have a very high day case TURBT rate. And that was highlighted in our GIRFT report. So I think we had the highest day case rate in the country actually for those. So most of our TURBTs and actually our TURPs are done as a day case. We've got a very good day case pathway for those.
I can see the benefits of it in terms of stays for the patients being reduced and the sort of morbidity being reduced for patients. I can see the financial benefits of it because you're not having as much in-care patient cost. How are you doing it and other people aren't? Why are you leading the way?
That goes back a few years, I think. So when I was a registrar working in Bath.
It's innovation through necessity.
To some extent, yeah. But I think the world is changing, or has changed over the last 2 years significantly with the devastating effects of the COVID-19 pandemic. And anyone wishing to get any of their operations through theatres at the moment and make theatre efficient and increase flow, reduce your bed base, has to look at innovative ways of thinking like day case pathways. And we were quite lucky really prior to COVID in that we were already doing day case TURBTs and TURPs. So we haven't really had a problem, particularly with the TURBTs, getting those through during COVID. So, and I think a lot of other hospitals have looked to that during COVID to get their caseload working again. A key to our day case pathway is the plasma technology, to be honest. You get such better hemostasis with that for both the TURBTs and TURPs than you would with the monopolar. So we're very happy that we don't irrigate afterwards on a routine basis. And a lot of other places do still, and that necessitates really the patients having to be an inpatient. Whereas what we tend to do give them self-irrigation with frusemide and some tranexamic acid at the end of the procedure. And then they have a two-way catheter.
What's it looked like for the last 18 months?
So I think all hospitals have been different depending on how they've been hit with COVID. We were quite lucky in the Southwest in general that we weren't hit specifically heavily within our ITU. And there were a lot of preparations in the first wave. So we risk stratified all of our patients using the very helpful things like the BAUS guidelines that have been produced to help us all risk stratify. And we did stop a lot of our cancer activity or risk stratify our cancer activity in the first wave. But having said that, we in the Southwest weren't hit anywhere near as badly as we thought we might be. So actually all our preparations to some extent were not necessary, which was a lovely situation to be in. And then after that, we haven't stopped. So no, all of our TURBTs have essentially carried, and other services have carried on as normal oncologically after that. TURPs, yes, they did stop for quite a while, but no, we restarted those probably about 9 months ago. So we're in a very lucky position. We don't have a huge backlog at all in Bristol, but I know other centres aren't in the same situation.
And you're getting through them nice and quickly as well from a surgical point of view as well, it sounds. So that's good. Other surgeons that we've spoken to are awaiting the inevitable increase in muscle invasive disease caused by a lack of activity during the pandemic. What are your thoughts on that?
I think that is a significant worry. I do actually. The hematuria referrals do seem to have dropped.
Yeah.
And so the worry is that there's a lot of people sitting out there with bad disease that have yet to present. I don't think we've had a sudden increase in our cystectomy rate that I'm aware of. So I don't think we've hit that at the moment, but we certainly have seen anecdotally a number of late presentations because of COVID, because people didn't want to present to their GP or felt they couldn't at the time.
When Intuitive made the great leap forward of bringing in robotic surgery, the robots were going to be for cranial neurosurgery, reconstructive hand surgery, things that I can't even remember. And they've ended up as the device for the urologists. How on earth has that happened?
I think you just have to look at a patient who's had an open cystectomy on the ward afterwards versus a patient who's had a robotic cystectomy. It's an absolute game changer. It's just a completely different patient. And I think everyone's seen that. It's obviously used for cystectomy and prostatectomy and kidney surgery as well.
How many cystectomies do you do a year in Bristol?
It's one of the busiest oncology centres in Europe for cystectomies and prostatectomies.
What stage do you send your patients for radical cystectomy?
So that's a sort of slightly two-pronged question in some respects. So we actually talk to our patients about a radical cystectomy quite early. So all of our high-risk patients who would be fit for a cystectomy get talked to about a cystectomy at the diagnosis step. So even probably before we've done their restaging TRBT, we would be mentioning the option of a primary cystectomy to them, because we know the outcomes are so much better if they have a primary cystectomy in non-muscle invasive disease versus if they progress to muscle invasive disease and then have a cystectomy. However, that isn't the end of the story. So a lot of patients won't choose a primary cystectomy at that point. And I think if you were offered a number of different choices, you wouldn't choose that as your primary choice. So most patients don't opt for that. And really, it would be only the very high risk ones that we'd be pushing in that direction for very good reasons at the beginning. And then the second point, when we would be talking to them about it, would be when they'd failed intravesical therapies and either BCG or HIVEC, depending on what we've used for what particular situation.
There was, again, some discussion in Ghent. There were patient advocates who gave a very interesting and, in some stages, emotional session on their experience. A gentleman who'd had an RC who is an old colleague of mine, who's the director of training for Boston Scientific's urology division. So he understands the roadmap, and he's had a Mitrofanov and is very happy with it.
Yeah, we've got a hugely eloquent patient group, I think, in that respect, who've had cystectomies and are so supportive to patients coming up. One of our nurses, Helen Chilcott, helped set up the patient support group here, and they're an absolutely excellent bunch. They're really supportive. They offer a buddy system for any of our patients that even just wanting to talk about a cystectomy. And they're also proactive. There's nothing that they can't do, having had a cystectomy and ileal conduit. There's a skydiver, there's a horse rider. It's an impressive group.
However, I'll turn it back one page. We don't want you to do any cystectomies. It's a life-altering operation. There's a lot of new drugs coming in this area. The FDA are extremely keen to license anything that has a 30% recurrence-free survival rate at 6 months for BCG failure or BCG refractory disease. There are a number of new drugs available in this space. What's going to work? Nadofaragene, pembrolizumab, valrubicin. Where are we going with medical treatments, or are you just going to keep operating because surgeons like to operate?
So I thought you were doing very well to pronounce some of them there.
I know, but I've been practicing.
There's so many different options.
Well. There we go.
Yeah, there's so many different options now to have a think about and try and pronounce. They don't make any simple names for them. I think we may end up heading in that direction in terms of using immunotherapy for non-muscle invasive bladder cancer. And I think in the high-risk patients, certainly ones that have failed intravesical therapy and are not fit for cystectomy, it is potentially a good option for the future. The thing that concerns us still, and when I've talked to patients about it still, is the side effect profile is still pretty high. And high risk for something that is still non-muscle invasive. And I think that's where the concern is, particularly because most of the patients that we're looking at currently in using these medications are not fit for cystectomy, which therefore means that their performance status isn't great, and then giving them a medication that can have relatively toxic side effects systemic, can be quite concerning for some of them, and a lot of them are elderly. So currently the answer is we're not currently involved in any of the trials. We're massively interested in what's happening in the trials and keeping an eye out on all of the medications. Do I think they'll come into the fray at some point? Yes, I think so, definitely. I guess my only concern is that whenever we put drugs into the fray and offer patients to those versus a cystectomy, when we know that they're potentially oncologically inferior, patients would tend to choose the drug over a cystectomy. Yes. And so I think we would have to very carefully be counselling patients if they were fit for a cystectomy and still wanted to go down one of the other immunotherapy routes. Although I guess you don't know what the recurrence-free survival might reach in the future. At present, it certainly doesn't compare to a cystectomy.
So if a patient come in with high-risk disease, you give them BCG, they recur at 6 months. You've done a re-TUR, you've given them a full 1-year dose of BCG, you gave them immediate post-operative chemo, and they fail at 6 months with a recurrence of high-grade non-muscle invasive disease. What do you do?
We'd offer them HIVEC. So we're very happy with the combat system, but if the patient is fit for cystectomy, then very obviously that is the oncologically superior treatment for them. If for whatever reason they cannot have that or they do not want it, and we do have a lot of patients that really just can't stand the thought of that, then HIVEC is certainly a very good option for them, offering them a very good chance of recurrence-free long-term survival. So that would be our choice. We occasionally do talk about reinduction BCG. I think if they'd failed at the 6-month mark, you probably wouldn't be talking to them about that. If it's slightly longer out, you may think about a further course. But also looking at the side effect profiles, BCG it does have a much higher side effect profile and really can affect quality of life more than HIVEC. And so we're quite honest with the patients about that. And in fact, we are finding some patients that wanting to have high-vac over BCG who are BCG naive patients purely based on the side effect profiles.
I know what bladder cancer treatment looked like 25 years ago, when it really was BCG, mitomycin or nothing. We've moved on a little bit today. I think we have finessed wonderfully with better TURs, better visualization, better adherence to things like immediate post-operative dose, better understanding of stratification of the drug. So I would say 5 years ago that we hadn't moved on at all in a generation. I think we've moved on non-surgical treatment a little bit now. I've parked the DeLorean in the car park in Southmead Hospital and paid the 300 quid parking charge, and I pop you in it and move you 25 years into the future. What does it look like then?
Well, I very much hope we've found a cure with a tablet, and so we don't have to do any surgery. We can all give up and retire. I think, in truth, I think urinary biomarkers are probably going to play a much larger role. Maybe this is more not necessarily 25 years down the line. I'd say in the next 5 years, I think urinary biomarkers as a part of diagnosis and surveillance are going to be much more prevalent in the NHS. I think the use of MRI to stage bladder cancer is probably going to be much more standard. And it may be that we don't end up doing a TURBT as a diagnostic test anymore, but just as a treatment. Mm-hmm. I think MRI is going to play a large part in terms of diagnosis. I don't think we'll come up with anything that will completely replace scopes, I have to say. I don't think there's going to be nanobots or something like that operating inside the bladder in 25 years' time, maybe a little bit longer than that, who knows. I suspect we're still going to be diagnosing with scopes and treating with scopes. I think en bloc will probably take over as the method of removal. And I think the only technological issue stopping that at the moment is a retrieval bag for the specimen.
That's right. At every bladder meeting I've ever sat in, they ask the question, who here gives post-operative chemotherapy? And about half the hands go up, and then there's a debate. Now, you said right at the start you do that, and that's not new, that's not innovative, that's just adherence to guidelines, and it's still a category B recommendation in the guideline, I think, which is, pretty much you must do it. But half the people don't do it. Is it important? And if it is, why don't people do it?
I think it's massively important. And the evidence coming out is that it's more important actually for the intermediate and the lower risk groups than actually the high risk groups. But the burden of bladder cancer is really the recurrence and the follow-up and the surveillance. And if you can reduce that recurrence and the amount of times people need operations and surveillance, I have to say I can't understand why people aren't giving it. I've never understood why some people don't, and it might be logistics, that some people still struggle logistically to do that in the theatre. Again, I'm not quite sure why. It seems relatively simple and straightforward.
I've offered you a trip into the future. So benevolent am I with imaginary gifts. I'll offer you another one now. Due to Boris Johnson's great love of the West Country, he has given £25 billion of research grant to the Urological Institute at Southmead today. What are you going to spend it on tomorrow?
25 billion is a large amount. I truly think that biomarkers are the way forward in terms of trying to reduce the surveillance for bladder cancer. So I think I would, throw my money at a number of different, if we're having lots of money, a number of different biomarkers that look promising, and see if we can get a better surveillance schedule, which has less intense.
With a view to a greater understanding of the disease, to be able to specifically tailor treatments, or what does that look like?
I think both, really. I think both. If we could pick up the people that weren't going to respond to BCG, for example, if we could pick up the people that weren't going to respond to chemotherapy before cystectomy. So if we could drill down into the genetics of the bladder cancer before we started the treatment, and we knew that the treatment was going to work, that would be absolutely amazing. Starting that already with the PD-L1 inhibitors, aren't they? So, that it is coming.
As a woman working in surgery, especially working in urology, how has that changed in the last 25 years? It's 25 years ago, it would have been seen as a great innovation to have any women working as consultant urologists. There are a few around now. What comments do you have on this? Perhaps somewhat contentious.
There's several hundred of us around now, which is absolutely lovely.
Which is excellent.
And in fact, we have a Women in Urology WhatsApp group, so we're all connected, which is even better. Very ably led by Joe. So that's lovely to be connected to so many of them. They we were talking earlier, but I can put this in here. But one of the first consultants I ever worked for in my urology job didn't think women should do surgery. So just
any surgery, okay, fine.
No, any surgery at all.
That's a pretty broad brush.
Yeah. So I think that was a challenging job. Luckily, my other consultant, Seamus McDermott down in Torbay, was excellent and did believe in women in surgery and was a brilliant mentor. And that was one of the main reasons I wanted to do urology. But obviously those views have luckily changed over the years, and people have accepted women are very good surgeons, equally as competent as men. And I think it is, well, diversity in general is coming to the forefront, not just with women, but there's a lot more of us now. So our trainees coming through, I think in the Southwest, the females now outnumber the males in our trainees. Spouse have an excellent agenda with that, and trying to increase diversity in all of their previous manuals, I think they're called. Mm-hmm. And certainly the Bowes Oncology that I'm going to and chairing at this year is a very diverse mix of people. So I think Bowes are moving in a really good forward direction regarding that.
Thank you very much for joining us. It's fascinating to hear from a busy and important uro-oncological centre in the UK and in Northern Europe, to hear what's being done now and what you expect to be done in the next 5, 10, 25 years.